Thank you, Maurice. It's a real major honor to be here today as part of this wonderful Congress. Hopefully, if you put a little patience on my English, probably you're going to take some interesting information home about everything that is going on today related to digital dentistry. My major intention today was not to put together a complicated case, but rather a very simple case, because my message is to understand that digital dentistry is a process of transfer of information, and once you understand how that process of transfer works, you're going to easily implement different techniques in your practices. I want to thank the different companies that have helped me put this lecture together, because there are major resources in creating all the imaging and major resources related to technology. My objective today is to cover the decision-making process to successfully work digitally, to scan the different preparations or abutments in our patients, to be able to mill or print restorations and deliver successful cases at hopefully chairside. And we all have been part of the big explosion in computer-guided surgery, the development of CT, the development of interactive software, the scanning appliances, and stereolithography. It has been part of our career, but what is going on now is a different explosion. It's the explosion of the in-office intra and extra-oral scanning, the 3D milling, and the 3D printing. And it's interesting because these two technologies have been going and have been developed hand on hand. They pretty much happened kind of at the same time when Dr. François Duret in France in the 70s had that great vision of making optical impressions, making computer-generated models about milling and about biomodeling. Basically, Duret is the father of everything that is going on today, but the person that made it a reality was Werner Mormann with the invention of CEREX. So when you put together the creation of the CBCT and the creation of the digital technologies, being that scanning, design, milling, and printing, what we have to think is of the creation of something that have been the dream of the dentist, putting the implant, putting the abutment, putting the crown the same day, or prepping the crown and prepping the tooth and delivering the crown right away. And this technology has been available for a long time. We all are familiar with the technology of CEREX. We are all familiar with Implant, the interactive software, but these are technologies that work as closed architecture technologies. Basically, you cannot share the information with other models or other devices that are not within the system. So the big explosion has been with the creation or the explosion basically of the open architecture models. Technologies and devices that now can communicate universally between themselves. And when we are talking about this kind of technology, we have to think of a file format that is called STL. And it's a file format that was developed in the 80s, in the beginning of the 80s, by Mr. Chuck Hall, who created a company called 3D Systems. And this technology is basically no different than the JPEG files that you are creating when you are taking pictures with your camera, but it's now a three-dimensional file. And it's doing this. It's doing exactly the same that we were doing with our Facebook and we were doing with our byte registrations. Basically, it's a format that we use to transfer. And now what we are doing is transferring STLs into computers to create virtual articulation, digital articulators. The STLs are now utilizing every single aspect of digital dentistry. We're using it for CBCT, we're using it for interactive software, our milling machines are actually utilizing these formats, and the printers. And when we're making the decision of buying software, an interactive software, one of the things that we need to consider now is not only the modules that we have within those softwares, but we need to decide if we need to have an STL exportability. Because some softwares are going to allow you to export or import STLs, and some other softwares are not. And if you're planning to do some of this process in your practice, or if you're planning to communicate with the lab, you are going to need STL exportability. So open architecture is a major player today in what we're doing in dentistry and in implant dentistry. And as I said before, this is a process of correlation and transfer. Correlation and transfer. And that correlation and transfer started early in the development of all these technologies with the utilization of the scanning templates and the scanning appliances. We were trying to introduce some radio opacity in the work that we were doing. Now, this correlation and transfer is also done digitally, utilizing dual scans and intra and extraoral optical scanning. So basically, today in edentulous patients and in some partially edentulous patients, we're utilizing the dual scan module. And the dual scan module allows us to do some of the planning and some of the calculations before we go into computer-guided surgery. The second technique that we're utilizing, and that is basically dominating the whole process of planning, is the optical scan technique, which was initially utilized when we were having the presence of heavy artifacts. But this technique is the technique that now is dominating pretty much everything that we're doing in digital dentistry. Because now it's redefining dentistry because there's so much that we can do with it. We can examine our patient digitally utilizing this type of scanning processes. We can plan our work. We can guide the fabrication of any type of device. We can create biomodels utilizing these models. And we can make also our prosthetic work utilizing, again, optical scanning. So optical scanning has completely redefined dentistry, and it's nothing that would bite you. It's something that you have to sit down for a while and try to understand the process from A to Z to be able to make it happen in your practice. So several years ago, it became evident that at some point we were going to scan, we were going to design, we were going to mill and or print chairside in our practice. And the main question that we had was, what would happen? What would be the short and long-term behavior of an immediate ceramic crown? Because usually we have been talking about the behavior from the occlusion standpoint, and that's the reason why many of us were utilizing acrylics and composites to do final restorations on implants. But the other question is, what happened at the soft and hard tissue level? So we decided to create a pilot study and to create a model with like trying or exploring the different technologies that we had available at the time. And we started that study back in 2008. We had the optical scanning available, the stereolithographic models, the interactive technologies. So the big question was, could we have final crowns made before implant placement? How stable would that be short and long term? And we made two groups, the tissue punch group, and we made the incision flap group. So this is one of the first cases that we did, and this was back in 2007. It was the removal of a major inflammatory cells cyst with the graft of the site. And we started the prosthetic management of the site, doing a dynamic perioprosthetic management of the ovate pontic that we had created within the device. But also, we started a process of impression, bite registration, and face bow, the process of transfer. And we did a scan, we did a plan, and everything went to the company that was helping us putting it together. At this point, we were working with Implant. And what happened was that Implant sent us back this model. This model is called an immediate smile model. And what we did with that immediate smile model is that we put the analogs of the case that we were doing, and we prepared the abutments in advance, and we also prepped the crowns in advance before placement of the implants. What happened then is that we went ahead and we did the surgery. We went through the process of doing the computer-guided surgery, utilizing the tissue punch, no incisions, And the 2 abutments were delivered right after the placement of the implants, and 2 crowns, 2 IMAC crowns, were delivered right after the placement of the implant. This is the same patient 6 months later. This is the patient 2 or 3 years later on a follow-up visit. This is the patient 2 months after that visit. And this is the patient 2 weeks ago. 2 weeks ago. So the answer is when we have a tissue punch case, these crowns are going to stand a chance. And what you are seeing over here is basically the fact that these crowns of the pilot study, we cemented with 10 bond. We cemented with 10 bond because we didn't know what was going to happen. We didn't know if we were going to need a new set of crown, and we didn't want to destroy the abutments. So this crown had come loose. The patient came back, and anytime that we're going to deliver a crown, we first sit the crown, make sure that it's going all the way down, because sometimes the soft tissue don't let the crown go down. So at this point, the crown had not completely seated into place. Now, can we have final crowns made before implant placement when we are doing an incision and when we have a flap group? So interestingly, we had this patient also, 2009, patient with a major cavity in the furcation, in the furca. And we used a technique that we were developing at the time, which is called the all-in-one appliance. We made a scanning appliance that would be the surgical guide and would be the temporary device. We went through the construction of the device and created the reference points, created the diagnostic placement sites, the DPS, which is a concept that we developed together, Dr. Picos and I, several years ago. And it's a concept that goes along with the triangle of bone of Dr. Gans. We put together some sleeve guides to guide the burrs. And what we're doing here is that we are painting the device with nail lacquer and barium sulfate. My wife started to realize that her nail lacquer was disappearing, and she found it back in my lab, in my practice, because nail lacquer is an excellent device that you can use to create radio opacity. And what you are going to see is like a halo, and that halo is going to give you an idea of the anatomical contours of the device that you're utilizing for your planning, and you get a 360 degrees anatomical information. So it's an excellent technique to guide implants. We did the removal of the bridge. We noted that we had a major bone defect, but also a soft tissue defect. So we decided to apically reposition the tissue to utilize some of that good tissue, some of the good connective tissue that we had available. Went through the whole planning, and we rehearsed the whole process so we wouldn't find any kind of unexpected situations, and we would know exactly when, where, and how to graft in that area. So this is the step-by-step process. Implants are placed. Open tray impression is done right at the time of implant placement. That impression goes to the lab, and what we requested was that the lab would prepare the crowns overnight, IMAX crown. So the patient goes with the same devices that we had used to create the guides, and this is before and after the soft tissue. You can see the improvement of the reach and the improvement of the area and the placement of the implant. And one of the things that was concerning me was the fact that I had that defect in the extraction site next to the implant. This is 2 days later. Actually, we remove the crowns and we do a follow-up scan to see the actual position, and plan and delivery of the case was perfect, was exactly as we had intended. These were the ceramic crowns that were prepared overnight, being delivered, and look at the space that we have in that x-ray. That was a little headache that I had because I didn't know what was going to happen because these crowns were in occlusion. This is 3 months follow-up visit. Look at the behavior of the tissues. I don't like it. We had a temporary crown here. We didn't want to put ceramic crown here because we knew anyway that we were going to have to make some changes there. This is 1 year later. We are preparing a new set of crowns, but you can see actually the evolution of the tissues, the behavior of the tissues. It's a nice result. I don't have the delivery picture that I took right away. I don't know why. But this is 5 years later. This picture is taken 2 years ago. So the answer to the questions, do we deliver permanent crowns when we have incisions or flaps, the answer would be no, because if you do that, you're going to need 2 sets of crowns, and you're going to put the whole area in danger. So if you want to spend some time and spend some money in doing 2 sets of crowns, then that's a possibility. You're going to have beautiful temporary crowns made in ceramic. But when you're working with the tissue punch technique, yes, definitely, there is a possibility of delivering ceramic crowns. And this is the actual radiographic behavior of the site, and it got a beautiful behavior. So I was actually very happy with this case, and we did 10 cases of each, 10 cases with tissue punch, 10 cases with incisions, and the behavior was pretty much the same. So now the big question is, how do we go fully digital? Because now we have technology available, so the technician doesn't have to overnight crowns. We can do the crowns in 10 minutes. We can place the implant, place the abutment, scan the patients, and deliver the crowns. So how do we go fully digital? We can scan the patient, we can make the design, we can mill, we can print, but it has to be software friendly. It has to be software friendly. Back in 2007, 2008, we were going crazy, Dr. Picos and I, trying to figure out all this technology and how to put it to work together, because the software was the big problem. Communicating the device meant sometimes doing reverse engineering on the available softwares, and it was hell. So basically, when you walk out of here and you decide to visit the different companies that are presenting these technologies to you, it's not just about what the technology can do for you, but how are you going to deal and cope with the technology? How are you going to be able to play with those devices without getting beaten by the computerized process of doing the work? So it has to flow. So this is what we're working on now, because doctors are buying the devices, but sometimes we get confused on the protocol. There are no written protocols. There are no set decision-making processes. So this is my contribution for you today, because this is the way that we have been doing it in our practice. Hopefully, some of you might be able to get some of this into what you are doing. We have 3 different situations. We have a scan with a scanning abutment. We can have a stock abutment, and we can have sometimes situations in which we have so much blood at the time of implant placement that everything goes crazy. So what do we do and when? When we have a scan and we have a scanning abutment, you know that you're going to scan that scanning abutment, so blood is not going to be a major issue, and you're going to import that or export that into the design software from your scanner, from the intraoral scanner that you are using to capture the information. From the design software, you're going to design whatever type of device that you're going to make, and then you have options. One option is that you will produce abutment and crown. The other option is that you might have to 3D print. I have a friend in Taiwan, and he went ahead and he bought an intraoral scanner. He took it into Taiwan, but there were no digital labs in Taiwan at the time, so the intraoral scanner was good for pretty much nothing. He couldn't use it to do his restorative dentistry. So what you have to understand, because we have people here from different countries and different places, is that in your area, the technology might not be there yet. So you might have to import the whole set of technology into your specific geographic area. So if you're going to use a scanning abutment, also keep in mind that it means that you're also going to make the abutment, not just the crown. So you use a scanning abutment when you're planning to make the abutment and when you're planning to make the crown. There is a big problem with the abutment, and it's the fact that I'm not a big believer in some of these milling devices, milling abutments, because the abutment is as strong as the connection mechanism that you're going to utilize to put together the 2 components. So I believe in abutments when you're using more complex, more powerful milling machines to make the abutments. But I don't have a problem with the crowns. I think that the available technologies for making crowns today work great. For abutments, I'm a little bit more hesitant. Now, the second option is when we are placing on that implant that we had just surgically placed on that patient, when you're placing a stock abutment. Because most of the implants today are going to be placed very deep into the bone, because we want to have the platform switch effect, and we want this bone to grow on top of that platform. So now that implant is going to be very deep, which means that we're going to have to calculate the size of the cuff of that abutment. And also, we want that finish line likely to be subgingival for aesthetic purposes. So what's going to happen is that the scanner is not going to be able to reach far into the finish line of the stock abutment, which is going to become an issue. So you're going to have to decide if you're going to utilize a stock abutment, supragingival, and that would be if you're working in the posterior area, right? Or if you're working in an aesthetic area, you need an additional technique. So if you're using a stock abutment, you're going to be able to scan your stock abutment, likely supragingival. You're going to have to export that into your design software to produce a crown. You can also 3D print and give it to a lab technician. 3D printers today are now $5,000. So they went from $300,000 to $5,000. It's getting cheaper. The third technique, it's when you have the finish line subgingival and you have a lot of bleeding. So what's going to happen is the fact that you have options. You can scan a scanning abutment, which means you're going to have to work with making the abutment, or you're going to scan with something that we like to call the quick model. And I'm going to show you in detail how to make the quick model in your practice. So these are the three different options that we have. We can actually scan the scanning abutment. We can actually place an abutment kind of at the level of the gum, so we can actually capture the finish line, or sometimes when we have a lot of bleeding, we need to do the quick model. So let's go to the first process. The first process is scanning from a scanning abutment, exporting to a design software to produce mill abutments and crown from digital file, or to basically 3D print. So this is a simple case, as simple as it gets. Beautiful ridge, beautiful tissues. We did the extraction, we did the socket preservation, and now the patient is back, and we are tissue punching. We are doing the preparation, and we are trying this interesting system, which is a system that is being specifically promoted for digital work. Basically, the way that this system is presented is they have everything that you need to work digitally. They give you the scan, they give you the scanning bodies, anything. It's created academically and scientifically to work digitally. So we place the implant, we place the scanning body, we go ahead and we proceed to do the tree-shaped intraoral scan, and now we are ready to export this into our software. So what do we do next? Get into the software, digitally place the analog, digitally place the abutment and create the abutment. This abutment, all we have to do is press a button and mill, and also digitally create the crown. So full digital work, digital abutment and digital crown. This is an easy procedure to do. Just keep in mind that the in-house devices that we are getting into our practices today might not be the best devices to make the abutments. You might need to talk to a digital lab and have them make your digital abutment. But this is right before printing, and this is some of the technologies available out there. This is an interesting milling device, very powerful, that is being utilized, and this is kind of the results that you get directly from the milling and after polishing. This is not equivalent to what my technician is doing in my practice. I pretty much don't like the anatomy. I pretty much don't like the finish, and I'll show you what I mean with that later. So when you are working with this and you forget about glazing, you forget about staining, you forget about crystallization, you are giving away a lot. And you have to decide if that's how you want to do it. You might be in an environment in which that might be the way to go. The second option that we mentioned was scan and stock abutment, send the information to a design software to produce either a crown or to print. And this is how we did it. Same patient. We placed the stock abutment in place. We use the radio frequency to control the bleeding. We go ahead and we scan the patient. This goes into the design software. From the design software, for this specific case, we use CircumScan, the CircumScan machine, the M1. And this is the result. This is what we get. the difference here is not the milling machine. The difference here is the fact that we went ahead and we spent some additional time creating a process that is known as crystallization, plus staining, plus glazing. And now, this is not a 10, it's not a 15, it's not a 20-minute crown. Now, this is a crown that took some time to put together to create those effects. So what it happened here, utilizing the blue blocks, is that we have a transition from blue to the original selected color. And this is the crown that is ready for delivery. Big, major difference between one crown and another, and this is the final result. And this is right after implant placement also. So this is the difference between just going from machining and forgetting about it, and this is the difference from adding some additional art into the finished work that we have been doing. You choose how to work because the technology is available for you. So basically, this is Rafael, my technician, and this guy is the one that always gets the kisses and the hugs from the pretty patients. We've been working together for several years, and I'm very proud to be his friend and to work with this guy, an artist. This is the other technique that I had mentioned to you before, and it's known as the quick model. And the quick model is pretty much indicated for extraoral scanning of abutments with subgingival finish line. So anytime that you are doing a case, you're placing your implant, you finish placing your implant, and you decide that you are going to do the preparation of your crown, basically, I suggest that you introduce this very simple technique into your practice. The material that you're going to be utilizing is vinyl polysiloxane. It's been available for several years. It's Parkel. Are you familiar with Parkel? Parkel has a product, it's called Mac 2 or Mac 3. It works very well. But in 3 minutes or less than 3 minutes, you're going to have a good working model ready for scanning. So basically, you're going to place your implant, and this is the same patient because this patient had 3 different sets of restorations, same different techniques, same procedures. And you're going to take an open tray cupping. You're going to make an impression, open tray impression, and you're going to pour the material. And before pouring the material, you need to lubricate the material. Make sure that you lubricate the impression so you can separate the material, because otherwise it's going to glue together, it's going to get glued. What are we going to do next? We're going to go ahead and we're going to go from that working model, remove this device, look at the finish line, select the abutment, make sure that you get enough interocclusal space, select the right angulation, whatever. This case was ideal, so it was pretty much easy. And all that you have to do is take a surgical blade, number 15, and trim the finish line. Trim the finish line. And this is what you're going to get now. See, you're going to have a very nicely exposed finish line that your scanner is going to be able to capture. So now you are not fighting inside the mouse. The patient doesn't have to be for a long time with an open mouse. You don't have to be repeating scans. The crazy work is out. You just pick it up, take it to your lab, right in your office, and do the work that you need to do. Simple. And this is what's going to happen next. Once the scan is done, what you're going to notice is that you have the most perfect finish line that you can imagine. Beautiful. The sweating is over. I've been utilizing this technique since 2001 when I got the ZX2 in my office, and I was going crazy with that ZX2 because the ZX2 wasn't as easy as the type of models available today. So I had to, instead of fighting with the patient, fighting with the bleeding, I had to figure out how to take everything out and work outside, calm, and sometimes tell the patient, come back tomorrow or come back in 3 hours. So this is what was happening. This is where it comes from. So now that crowns go into the design software. You put together the anatomy, you put together the dimensions, you set your occlusion landmarks, and you're ready for milling. And what are you going to get? Whatever you spend the time in developing. It's not the 10 or 15 minutes of the milling machine. It's what you have to do after those 15 minutes to enhance the cosmetic appearance of that crown. And again, this is the crown. delivered and cemented right away. 3 different techniques on the same patient, the same result with the 3 different techniques. So the message is, I want you to sit down with yourself and put together the process of thought to be able to implement this technology in a simple manner back in your practices. Back in your practices. Because, again, the technology don't bite. It's the fact that it's being thrown into us without solid protocols, and we have had to put the protocols together because we have been sweating to make it work. I hope that you all wish me luck, because very soon I'm going to be attending some competitions, some free diving. So hopefully I'll make it for next year here with Maurice and all the Atlanta team. And to finish, this is a very interesting case in which I did not utilize the quick model. This is a case in which we computer-guided an implant. We intraorally scanned the abutments, and we did some chairside milling for immediate load. This is the whole planning process that we had to go through. These are the biomodels that we fabricated. And if you see here, what we have is a nice congruence or merge of an optical scan with an actual scan with virtual teeth and implants. So now, a surgical guide is fabricated, and we bring it to the patient. This is a patient that for several years have been missing 1 premolar and a molar. My patients are clenchers and heavy bruxers, because my practice is a TMJ practice exclusively, and we do implants on the TMJ patients. So it's a situation that sometimes gets interesting, because a contraindication for immediate loading is parafunction. And one of the things that we do with parafunction is that we utilize Botox on the masticatory muscles to decrease the parafunction, and we also utilize appliances. So if you were paying attention carefully to the cases, all the cases had either wear facets or cracked or craze lines, evidence of parafunctional habits that have been happening for several years. So these are the surgical guides that have been prepared. The first case that I show you, we did it with Implant. This case was done with an interesting software called 360 DPS. And the first thing that you need to do is make sure that the guides have good fit, good stability. I love to use Thompson sticks, because that allows me to mark the area in which I'm going to get in there with the tissue punch. And once you mark the area, this is another device that I love to use, and this is one of the things that I actually learned from Dr. Picos. Radio frequency is fast, is safe, is quick, and very friendly on the tissues. So basically, we didn't use a tissue punch this time. We used radio frequency because it helps me with the hemostasis. This patient bleeds a lot. And now we are doing the computer-guided process. These are Chinese implants. This surgery was done out of the country, Chinese implants, because Chinese are getting into the implant market, so beware of what is coming from those guys. These are the actual implants placed. And what you see here is an X-ray right after implant placement, and we always take a backup impression. Anytime that you are working with intraoral scanning and implants in immediate loading, you're going to do 2 things. You're going to do your intraoral scanning, but you're also going to take the impression so you can implement what? The quick model, in case that your intraoral scanning is driving you crazy. If you try to get it and try to get it and try to get it, and you keep on getting blood and you don't get the finish line, just go into the quick model. It's going to be faster than fighting, or faster than trying to coagulate the area. So this is what's going to happen, the same that I show you. You pick up the model. So that model is being poured just as I show you, and you go over here and try to do your intraoral scan. And as you can see here, we purposely left the finish line supragingival. This case was done with the OmniCam. It goes into the software, and in the software, we're going to do all the process of planning and computer-assisted manipulation of the design. Excellent system, excellent camera. I have in my practice 3Shape, and I also have iTero. 3Shape is a great system, which is what we have been using mainly. But this is also a very good system that works very well. I don't like it because it's closed architecture. So we go back to the situation of being closed or being open architecture. It's a decision that you have to make in your practice. You want it simple, closed architecture might be for you. You want it a little bit more daring and have more freedom in what you are doing, open architecture might be for you. But basically, we go ahead and we outline the finish line, we do our crown design, we go into the milling machine, and we mill the two different crowns. This is lava, so it's a semi-permanent material. I've been blessed that I've been able to pretty much work with every single system out there, and pretty much all the systems are working very well. They all have limitations. Some systems do things that other systems don't do. And that's why I'm telling you, you have to do your homework very carefully, because there is a considerable amount of money invested here. When you go digital, you're going to spend $100,000 to $150,000 for the whole package, not counting the CBCT machine. So you're going to be easily close to $300,000 in investments. You have to be very careful. But you can see that the finish line that these machines are giving us today are very good, They are excellent. The finish line is created by you and your eye, by your ability to design and outline that finish line. So now we have the crowns ready for delivery, and we always cement these crowns with 10 bone, because again, these are part of a major pilot study. We are putting cases together, but look at the situation here. If we were working in upper premolars, canines, laterals, or centrals, this would be an issue. And that's why the main message that I wanted to send you today was the possibility of implementing the quick model into your practice. The healing is fast. The healing is pretty much always good. It's a week later, but we know that these crowns are likely not going to be permanent crowns. These are fancy, temporary crowns. Fancy temporary crowns. If we would have gone into the quick model and utilized the quick model, this finish line probably would have been somewhere around here. I would have probably chosen to utilize a different block and mill a ceramic material. But it makes the case for what I was explaining to you. So the conclusions, the technology is rapidly evolving. There is a major investment that you are making in your practices. When you make that investment, you need to have a plan. You need to get into that investment with a solid plan in mind. How is it going to pay back? How are you going to implement it into your patients? What is it going to do for you in your practice? So you need a comprehensive process of analysis, not just the fact that you're going to have to spend time in the training to be able to get the expertise, because you want everything to flow as you are doing the process. And it brings another fact, and it is the fact that you are probably going to need a dedicated virtual assistant in your practice. You might either want to have an additional employee that is going to be somebody techie with a background in design, or you might actually going to have to make an agreement with a company that will remotely access your computer and make all that design. So all you have to do is load the cartridges, load the blocks, and these people are doing everything from Atlanta, from Arkansas, from Texas, from whatever part of the world. With this, I thank you for your attention, and as I said, it's been a great honor being here today. Thank you, Team Atlanta, for the invitation.